So I presented the data of comparing cilta-cel versus ide-cel in the relapsed refractory myeloma patients who've had 2 to 4 lines of therapy. And this was a matched, adjusted, indirect comparison, okay? So cilta-cel and ide-cel are both BCMA targeting CAR T products, and they're FDA approved for patients who've had 4 or more lines of therapy. Now we have studies looking at these agents earlier in the treatment paradigm, earlier lines of prior therapy, comparing to standard of care, and they've both shown superiority to standard of care in both response, depth of response, and progression-free survival. But we don't have any randomized studies comparing the 2 agents to one another, right? And we're not going to have that, unfortunately. So in the absence of such ideal studies, we have to kind of take what we have, and we use this match-adjusted indirect comparison essentially to eliminate some of the bias when you're comparing 2 studies, right? So we're trying to match the patient populations by taking patient-level data from the cilta-cel studies, also known as CARTITUDE, and matching them, adjusting to what has been reported in the KarMMa study, which is what KarMMa-3 study, which is what used ide-cel compared to standard of care. And using this statistical methodology, they did identify that cilta-cel had a higher likelihood of achieving deeper responses, so 1.9 more times likelihood to get a CR or better, complete response or better. And not surprisingly, we know higher, deeper responses tend to be associated with long duration of response and progression-free survival. So we did see that cilta-cel was associated with significant reduction of progression or death at 49%. So this is, promising results there. Now, it doesn't negate the need for randomized controlled trials, but I think what it does, it gives us a different lens to analyze 2 drugs that you have, available for you in the context of 2 different, study populations. So it helps you look at it from a different lens.